next speaker is Yuliya Vengrenyuk. She's going to be talking to us about intravascular imaging, IVUS, OCT, and NIRS. Please join me in welcoming Yuliya.
Thank you, Beth. Thank you, everyone, for coming here. Thank you for inviting me again this year. It's very exciting to talk about imaging. This year, you all heard Dr. Sharma's presentation, Top 10, about imaging. There is so many very impressive clinical trials showing clinical benefits of imaging-guided PCI. So in my talk, I wanted to focus on very practical things, how specifically IVUS, OCT, NIRS can help in PCI guidance before procedure for lesion assessment, stent sizing, post-stent optimization. We're going to look at those specific criteria for optimal PCI and how these criteria help achieve very impressive clinical outcomes for the patients. And a little bit of special topic this year is calcifying nodule. It's a new emerging topic in treatment of the calcified lesions. Sorry. In my talk, I will be using our two mobile applications. You heard a lot about our library. So we have OCT for OCT, and we have IVUS 8 for IVUS. I'll try to incorporate as much as I can in the talk for you to see that. So we are going to start with lesion assessment with IVUS. The most probably challenging lesion is calcified lesion. Calcification looks as bright white features in IVUS with shadow, dark shadow, and IVUS can quantify the angle, length, and location of calcium as superficial and deep. This is calcified nodule. It's a protruding calcification into the lumen, and oftentimes it has a very irregular surface. Severe calcification is associated with worse clinical outcomes and has much higher risk of stent underexpansion. If detected, some kind of plaque modification technique should be considered. This is lipid plaque on IVUS, looking darker than adventitia, can also be characterized by angle and length. Sometimes we can see fibrous capillary line, this lipid. This is thrombus. IVUS has, sometimes it's hard to distinguish between lipid and thrombus. Very important for procedural outcomes. Lipid plaque can cause stent edge dissection and should be avoided in stent landing zones. This is IVUS 8. We have, if you want to learn more about lesion morphology, we have a specific section for this. We describe each lesion in detail. We have images. We have videos for each plaque type, and you can see there is a new feature compared to OCT. There is annotated, non-annotated image, and you can switch between these two, whatever is better. And so we have videos and images. I think another section of IVUS 8 is even more important probably than lesion morphology IVUS artifacts, because sometimes it's very difficult to distinguish between the real feature and artificial finding. For example, this IVUS guide wire artifact and motion artifact can actually look like a calcified nodule on IVUS, and reverberation artifact might look like stent strata in ISR or even stent malapposition. We explain how to detect those artifacts, and we also have quizzes to check your knowledge. On that, you can test your knowledge. Sorry, don't want to go back, but I wanted to say that you can do in any order. You can actually start with quizzes, because we explain every choice, correct, incorrect choice, and then go back to the basics, whatever works better. So this is pre-PCI stent sizing with IVUS. IVUS can help identify landing zones and detect lesion lengths and landing zones. Optimal landing zones are largest lumens with the smallest plaque burden. Vessel size or lumen size is measured based on IVUS also. So in IVUS 8, we have more than 21 case reviews, and we actually, since it's a very important topic using IVUS for stent sizing, we actually have 2 cases explaining in all the detail how to use IVUS for stent sizing. One case, I think this LED case has lumen-based stent sizing, and we have OCL LCX sizing based on vessel size. Everything is annotated and explained here. Post-PCI stent assessment with IVUS, the most important measurement, stent expansion, either stent area or the ratio, or another very important parameter, stent malapposition, which is characterized by the lack of contact between stent strut and vessel wall. Underexpansion might contribute to stent thrombosis in ISR, and malapposition is important only in the absence of, in the presence of stent underexpansion. At the same time, large regions of malapposition should be avoided, especially at the proximal edge of the stent. Another suboptimal finding on IVUS stent edge dissection, minor dissections can be ignored, but the major dissections propagating into the media, they are associated with the adverse outcomes, and they have to be treated. Tissue protrusion after stenting and thrombus also associated with adverse outcomes, and we are treatment depends on how extensive this protrusion is. IVUS 8 has a very detailed section on post-stent assessment, and we explain all these findings. We have a lot of videos and images. You can check this. You can check this section in in case reviews section. We also have real-life cases. These are cases from our cath lab. How we treated these findings, how we treated malapposition, why we treated this, what are the criteria for the treatment. IVUS and NIRS, a combination of IVUS and NIRS in one single catheter, allows us to use IVUS, all the benefits of IVUS, and also allows us to rapid detection of lipid-rich plaques. This is the NIRS chemogram, which gives us a quantitative assessment of lipid content in the vessel. LCBM more than 400 is associated with the high risk of peri-procedural MI. We have 2 cases in IVUS 8. We describe how we can use IVUS NIRS for pre-procedural for PCI guidance. I think one case was used to look at if we have lipid at the landing zone. Another case was stent sizing. Annotated, again, non-annotated images. So optical coherence tomography has much higher resolution, 10 to 20 times higher resolution than IVUS. As a result, we can see much better all the features located closer to the lumen. However, tissue penetration is only 2 to 3 millimeters. As a result, we are not able to see media or deep calcium in large plaques compared to IVUS. Also, OCT requires blood clearing. Plaque morphology by OCT, fibrous plaque, lipid plaque should be avoided at the landing zone. And the calcium characterization is more detailed. In addition to angle, we can also calculate, assess the thickness and the plaque area, calcium area. This is OCT characterizing eruptive, non-eruptive calcific nodule. We'll see a little bit later how it affects clinical outcomes. Red thrombus versus white thrombus helps identify the mechanism of acute coronary syndrome, plaque rupture versus plaque erosion. This is OCT lesion morphology section, similar to IVUS 8, has all the videos and a lot of images. IVUS OCT artifacts, very different from IVUS 8. If you really want to learn images, you need to understand this, because tangential signal dropout might look as a plaque rupture or even dissection. Or residual blood artifact actually looks like thrombus in many cases. So very important to understand the nature of this. We explain all of these features in this section. Then you can test your knowledge in quizzes. Pre-PCI lesion assessment, all done automatically. We have all the measurements right after the pullback is performed. We can have stand length and stand size right after pullback. Post-PCI lesion assessment, also automatic. These numbers are stand expansion, absolute and relative stand expansion. Malapposition is also detected automatically. High resolution OCT allows for all these automatic measurements. We have stand assessment in OCT, and in addition to malapposition stand expansion, we describe how to deal with stand edge dissection, tissue prolapse, in stand thrombosis. OCT has, as I will say, it also have very advanced search button. If you would like to learn more, for example, about malapposition, how to deal with malapposition, you just run a search on OCT or IVUS 8 also, and you're going to have all these cases, and you're going to see which case actually deals with this kind of complication. You can go in the case and to check what was our strategy. I think this is the most important slide. I showed it a couple of years ago. It's still very relevant. We have it in the cath lab. These are all optimal targets after imaging. Minimal stent area 5.5 for IVUS, 4.5 for OCT. No major dissection, propagating intermedia. Intimal dissections are fine, and only small malapposition allowed. So these are all post-PCI optimization targets. However, it's much easier to meet all those targets if pre-PCI imaging guidance was used. If optimal preparation strategy was used, stent under expansion will be avoided. If we select correct landing zones without lipid, we are not going to have probably stent edge dissection. Ultimate trial used this criteria to show that IVUS guidance provides much better outcomes for patients. What I wanted to show on the right, this analysis within the ultimate IVUS arm, and these are two groups of lesions which met all the optimal criteria, and 47%, even in the trial, still all the criteria were not met. And you can see that 1 year TFR was only 1.6% in the optimal PCI group, suggesting that it's very important not only to use IVUS, really try to achieve all these criteria. Dr. Sharma already talked about Renovate complex PCI. Also, this trial used this criteria for OCT and IVUS, and we could see that 56% of IVUS and 66% of OCT cases met optimal criteria. Despite of this, still intravascular imaging guided PCI led to much lower risk of death, cardiac death, target vessel-related MI, and clinically driven TBR. This is one of OCT studies which suggests that calcium-based score can predict stent expansion. There is maximum angle, maximum thickness, and the length. And all these parameters taken together predicted stent under expansion in this study. I wanted to show more recent study which included more cases and more calcified lesions. In this study, calcified lesions still had stent under expansion. However, only calcium length was an independent predictor in this study, so a little bit different patient population. What's also interesting, calcified nodule in this study was not associated with stent under expansion, which we see also in our cases. However, calcium nodule can lead to refractory ISR, as was described in this case report a couple years ago. And we also see this in the lab. So patient presented with non-STEMI, with calcified nodule in the ISR, in the RCA, and we can see that after procedure, there was a very good result with good stent expansion. Stent was compressing, the calcium nodule lumen looked very good. Despite of this, the patient came back to for PCR 3 times, 8 months, 11 months, 17 months after the first procedure. Every time the same lesion, and calcified nodule was protruding back through the stent struts. So the first time the treatment was drug-coating balloon, then drug-eluting stent, and only after that lesion was treated with laser, 17 months after original PCI, 1 and 2 year angiographic follow-ups were satisfactory. So in this new OCT study, it showed that eruptive calcific nodule actually is associated with the worst outcomes, despite of comparable minimum stent area and even better stent expansion compared to non-calcified nodule. So we published a couple cases reports. I think Dr. Sharma already showed them on treatment. There is still no consensus on treatment. We are using rotational orbital atherectomy, IVL, a combination of this, and right now we are working on a study looking at the effect of different treatments on this calcified nodule to resolve the paradox that increased risk of adverse events associated with eruptive nodule, despite achieving very satisfactory immediate results, post-procedure results. How to address ISR in calcified nodule? Not clear guidance. But of course, we understand that intravascular imaging is critical to understand lesion morphology and probably find a solution for this problem. And to summarize all of these findings, image-guided PCI improves clinical outcomes in complex coronary lesions. The trial shows that. IVUS OCT can be equally effective in achieving those results. Left main lesions should be considered for image-guided intervention. IVUS is preferable in ostial left main. And as we saw today in Melissa's presentation on ISR, in patients with stent failure, IVUS OCT are very helpful to determine the mechanism of stent failure. OCT, due to high resolution, has probably more beneficial in determining these mechanisms. Currently, imaging is 2A class recommendation, but we really hope that this will change after a couple large clinical trials will be presented later this year, and hopefully it will go to class 1. Thank you very much.